Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine an elderly patient who has a minor fall, seems fine initially, and then over the next few weeks becomes confused, unsteady, and drowsy. Or imagine a trauma patient who rapidly deteriorates with a low Glasgow coma score and focal weakness. In both cases, one diagnosis you must keep in mind is subdural hemorrhage. Before we go into the pathophysiology, let us quickly understand the anatomy that makes this topic logical. The skull has suture lines, such as the coronal suture, sagittal suture, and other junctions between skull bones. The dura mater is closely attached to the inner surface of the skull, and this attachment is particularly firm at the suture lines. This becomes very important when we compare subdural and extradural bleeding. Now think about the venous anatomy. Bridging veins run from the surface of the brain across the potential subdural space and drain into the dural venous sinuses. These veins are stretched between a mobile brain and a relatively fixed dura. So if the head accelerates or decelerates suddenly, the brain can move slightly relative to the dura, and these bridging veins can tear. Also remember the arterial anatomy. The meningeal arteries, especially the middle meningeal artery, run between the skull and the dura, often in grooves on the inner table of the skull. This is the key to extradural hemorrhage. Extradural bleeding is usually arterial outside the dura and is limited by the firm dural attachment at suture lines. Subdural bleeding is usually venous beneath the dura and can spread more widely. So a subdural hemorrhage means bleeding between the dura and the arachnoid mater. The usual source is torn bridging veins. The sequence is head movement leads to tearing of bridging veins, then venous bleeding collects in the subdural space, then the blood spreads over the cerebral convexity, producing a crescent-shaped extra-axial collection, and finally, this compresses the cortex and may raise intracranial pressure. The key image to hold in your mind is a crescent or sickle. Subdural hemorrhage is crescent-shaped because venous blood can spread widely across the brain surface. It can cross suture lines because it is deep to the dura, not trapped by the dural attachments at the sutures. In contrast, extradural or epidural hemorrhage is classically egg-shaped or lens-shaped because the blood is outside the dura and is stopped at the suture lines. Now let us connect the mechanism to the clinical picture. In an acute subdural hemorrhage, the usual setting is high-energy trauma. The bleed may be large, and there may also be underlying brain contusion or parenchymal injury. That is why acute subdural hemorrhage can present with rapid neurological deterioration, coma, focal neurological deficit, seizures, and signs of raised intracranial pressure. The dangerous endpoint is brain herniation. In chronic subdural hemorrhage, the story is different. The bleed is slower and venous. Over time, inflammatory membranes form around the collection, and recurrent small bleeds from fragile vessels can make the hematoma gradually enlarge. This is why symptoms may appear over days to weeks rather than immediately. The risk is higher in elderly patients and in alcohol dependence because cerebral atrophy stretches the bridging veins. When the brain shrinks slightly away from the skull, those veins become more vulnerable, so even low-force trauma can tear them. Anticoagulants and antiplatelets increase the risk of expansion and delayed presentation because hemostasis is impaired. Clinically, subdural hemorrhage has three main patterns to recognize. First, raised intracranial pressure. As the collection enlarges, intracranial compliance falls. This causes headache, vomiting, drowsiness, papilloedema, and a reduced Glasgow coma score. Second, focal neurological signs. The hematoma compresses the cortex, so the patient may develop contralateral weakness. If the dominant hemisphere is affected, aphasia may occur. Seizures can happen because the compressed and irritated cortex becomes electrically unstable. Third, chronic subdural hemorrhage can mimic stroke or dementia. Slow frontal or hemispheric compression can cause confusion, personality change, gait disturbance, recurrent falls, headache, and fluctuating cognition. MRCP trap. An elderly patient with apparent new dementia after a fall may actually have a chronic subdural hematoma. Diagnosis is usually with a non-contrast CT head. This is the first-line investigation because it is quick, available, and excellent for detecting acute blood and mass effect. On CT, subdural hemorrhage is typically crescent-shaped. It lies along the cerebral convexity and may cross suture lines. Acute blood is usually hyperdense, so it appears bright. Subacute blood may become isodense and can be harder to see. Chronic blood is often hypodense, appearing darker, and sometimes there is mixed density due to repeated bleeding at different times. When you look at the CT image, do not just identify the bleed. Look for the complications. Is there midline shift? Are the sulci effaced? Are the ventricles compressed? Are the basal cisterns compressed? These findings tell you about mass effect and raised intracranial pressure. Now compare the two classic shapes. Subdural, think S for sickle-shaped. It is a crescent-shaped collection that can cross suture lines. Extradural or epidural, think E for egg-shaped. It is biconvex or lens-shaped and is limited by suture lines because the dura is tightly attached there. This image contrast is very high yield for exams. Urgent CT is needed after head injury if there is reduced Glasgow coma score, focal neurology, seizure, signs of skull fracture, repeated vomiting, or high-risk anticoagulated patients. The key clue is not just the trauma itself, but neurological change after trauma, especially in an elderly or anticoagulated patient. Management begins with an emergency approach. Start with ABCDE. Correct hypoxia and hypotension because secondary brain injury is often what worsens outcome. Perform frequent neurological observations. Reverse anticoagulation when appropriate. Treat raised intracranial pressure and involve neurosurgery urgently. Large or symptomatic acute subdural hemorrhage usually needs urgent neurosurgical evacuation. This may be by craniotomy or decompressive craniectomy, depending on the clot, mass effect, cerebral swelling, and clinical condition. The aim is to remove the clot and relieve pressure on the brain. Chronic symptomatic subdural hemorrhage is commonly treated with burr hole drainage, often with a subdural drain to reduce recurrence. Small asymptomatic collections may be observed with close monitoring and repeat imaging. Steroids are not routine treatment for chronic subdural hemorrhage. If you remember one thing, remember this. Subdural hemorrhage is usually venous bleeding from torn bridging veins, forming a crescent-shaped collection that can cross suture lines. Extradural hemorrhage is usually arterial, classically from the middle meningeal artery, forming an egg-shaped collection limited by suture lines. Quick recall. An elderly patient on anticoagulation becomes confused and unsteady 3 weeks after a minor fall. CT shows a hypodense crescent-shaped collection crossing suture lines with mild midline shift. What is the diagnosis and why did a minor fall cause it? The answer is chronic subdural hemorrhage, because cerebral atrophy stretches the bridging veins and anticoagulation allows a slow venous bleed to enlarge. A trauma patient has a bright extra-axial bleed on CT. One collection is crescent-shaped and crosses sutures. Another is egg-shaped and stops at sutures. Which is subdural, which is extradural, and what vessels are usually involved? The answer is that the crescent-shaped collection is subdural, usually from torn bridging veins, while the egg-shaped collection is extradural, usually from arterial bleeding, such as the middle meningeal artery. Do subscribe to the channel for further videos.